Hello, my name's Dr. Stephen Lewis. I'm one of the intensive care consultants at Frimley Park Hospital. This talk outlines our current approach to the treatment of COVID-19 disease on the intensive care unit. Please note that I'm recording this in June 2020. In a few months' time, some of this may be out of date. As things stand, there is little robust evidence on the best way to treat these patients. What follows is a mixture of expert opinion, our own clinical experience, and learning that has been shared within the South East Critical Care Network. The first subject I'd like to address is how we decide who will be admitted to the intensive care unit. Now, these decisions will always be consultant-led, but national guidance does exist, published by the National Institute for Clinical Excellence. In general, patients who are unlikely to do well are those who have significant pre-existing lung disease, those with significant limitations to their physiological reserve, and those who are unable to comprehend or cooperate with a prolonged period of rehabilitation. Because what we've seen is coronavirus patients who get intubated take a long time to improve if they're going to do so and require a significant period of rehabilitation. At Frimley Park, we're supported by the presence of a medical HDU known as MADU, which is able to deliver non-invasive ventilation. One of the decisions that the intensivist is frequently called upon to make is to decide when to intubate a patient and place them on invasive ventilation. The process of intubation carries risks of its own, and once intubated, they will require deep sedation. However, leaving a patient on CPAP risks a catastrophic decompensation if they are unable to maintain their oxygenation levels. Currently, different centres gravitate towards early intubation or a trial of CPAP first. At Frimley Park, we generally trial CPAP before we intubate our patients. One of the difficulties is that they, despite being very hypoxic, don't appear particularly dyspneic. Our experience is to trial CPAP in patients who require more than 60% inspired oxygen. Sometimes we'll prone these patients who are on CPAP, which can improve their oxygenation requirement. We tend to consider intubating patients if they're requiring more than 60% of oxygen on CPAP to maintain SATs in the region of 94% and above. Our experience has been that, unlike in other disease processes, intubation and invasive ventilation of COVID-19 disease patients rarely leads to an immediate improvement in their oxygenation. One strategy that we have been using is to prone our patients. This means turning them on their front, and we'll leave them on their front for 16 to 18 hours a day. They'll require regular turns of the head and arms to try and prevent pressure sores. We have also stopped treating these patients as if they had classic acute respiratory distress syndrome. We found that using high levels of PEEP, that is positive end expiratory pressure, is often unhelpful, and also drying these patients out who are frequently dehydrated prior to admission also risks worsening of renal failure. Ventilating these patients can be very difficult. Frequently they will become dysynchronous with the ventilator, and we have a fairly low threshold for paralysing them, which is something we usually wouldn't tend to do. They can also produce very thick respiratory secretions, and we found that using a humidified circuit or regular saline nebulizers or mucolytics such as carbocysteine can improve this. In the intubated COVID-19 patient, achieving an adequate level of sedation can be difficult. Propofol and fentanyl infusions are what we would usually use for intravenous sedation, but if we feel that complications such as hyperlipidemia is occurring, we may choose to switch to morphine and midazolam. Additionally, we may choose to add in additional agents such as midazolam, clonidine or quetiapine, or several others that we have sometimes used. We've noticed that as patients begin to recover from their illness, they may remain profoundly delirious for many days. They may also have developed opioid tolerance or addiction and require management for withdrawal. COVID-19 disease appears to render patients hypercoagulable, and we've noted a tendency towards both micro and macrovascular thrombosis and appearance of pulmonary embolism. Therefore, with agreement with our haematologists, we have adopted an enhanced anticoagulation regime. We try to perform CTPAs on our patients to guide our therapy, where we feel the balance of risk favours doing so. Steroids may be used for several indications in COVID-19. They may be given to suppress a hyperinflammatory hemophagocytic lymphohistiocytosis or HLH state. They are also given to suppress lung fibrosis in situations where ARDS, acute respiratory distress syndrome, is felt to predominate. At the time of recording, the recovery trial has produced a preliminary report on the use of dexamethasone for COVID-19. They appear to have demonstrated that 6 milligrams per day of dexamethasone improves mortality in patients requiring oxygen or mechanical ventilation. Unless evidence to the contrary emerges, it's likely that we will follow this regime for future waves of the disease. Steroids may also be used for more general intensive care indications, such as vasoplegic shock or to reduce tracheal edema prior to extubation. As our experience with COVID-19 disease has increased, we have become increasingly reluctant to prescribe antibiotics without specific evidence of a bacterial infection. We do recognise, of course, that a secondary bacterial infection of the lungs can occur. A decision to commence antibiotics will be guided by the radiological findings, cultures, procalcitonin, and daily discussion with microbiologists. As I record this, evidence-based therapies for COVID-19 are only just beginning to emerge. Remdesivir has been shown to shorten recovery time, and it may be that we have access to this drug for future outbreaks. Dexamethasone has already been discussed. The intensive care unit is currently involved in several studies for COVID-19, and it was likely that patients will be recruited into these trials. In addition to the routine intensive care profile, we also frequently check ferritin, D-dimers and procalcitonin to help guide therapy. Due to restrictions on visiting, a member of the medical team will also call the next of kin on a daily basis to update them. Patients who require intubation for COVID-19 disease have a very guarded outlook. In fact, their mortality rate may be of the order of 65%. However, like many other centres, we have seen several patients who have unexpectedly survived. Therefore, we generally continue to provide life-prolonging care until we receive a very strong signal that to continue to do so would be futile. Thank you for listening to this presentation. If you have any questions, my colleagues and I will be happy to try and answer them.